So, as has been alluded to, one of the big questions about minimally invasive spine surgery is how do you define minimally invasive? And here to help us understand that better is Dr. Nima Alan from UCSF.
Excellent. I think it's still morning. Good morning, everyone. And thank you, Dr. Cantor, Dr. Ray, Dr. Kelly, for the invitation to speak today. And this is a great segue. Thank you, Phil, for the great talk on MIS classification. So I'm going to talk about how to define it. I don't have any disclosures. Does anybody know what this is? Anyone? Rorschach test? When I looked at this question, I thought of this Rorschach test, which is used to kind of gain insight into patient psyche and psychoanalysis, because this question can be interpreted in many different ways. I remember in college I used to see butterfly, now I can only see the sacrum. So what I'm going to do is try to break this question down to like smaller bite-sized questions to see if we can come to a conclusion. The first question is, can we measure this? Because if we can't measure invasiveness, it's going to be really hard to define it. And the question is that the answer is that there has been attempts in the literature to address this question, that through invasiveness index score. And this is the first attempt where they divided the surgery into an anterior and posterior component, and they had a score of 1, which was an arbitrary score assignment for decompression, fusion, instrumentation per level. So you would get a linear model, and they correlated that with blood loss and operative time as a measure of physiological stress to the body. That's going to be an important term to come back to, the physiological stress. So like I said, there will be a linear model. That's the dashed line over there, and that's the scattered plot. And you can see in the actual data, it does correlate with operative time and blood loss, and it's an intuitive model. The more blood loss you have, the longer the surgery is, the more invasive, the more physiological stress to the body. This was adopted in the adult spinal deformity through the ISSG, slightly different approach where they use a modified Delphi approach. So that's an expert consensus on what score should be given to different components of the surgery. And they also incorporated the magnitude of the deformity. And the same concept here, that they looked at operative time and blood loss again, and they did a better job than the initial score to explain more of the variability that I alluded to earlier. But what is the problem with an index score? An index score is an inherent limitation to our inability to measure what we actually want to measure. Because if you could measure the physiological stress to the body, we didn't have to come up with an index score. So you're looking at the shadow of the object to understand the phenomenon instead of the phenomenon itself. What is the answer to that question? Can we look at the object itself? Can we look at the phenomenon itself instead of its a correlate, such as an index score, operative time, and blood loss? And the answer is the technology is available to look at a single cell as a representative of what the organism goes through in terms of a physiological stress. You can see what genes are transcribed, what RNAs are expressed into proteins, and measure the physiological stress in the cell as a representation of what the organism is going through. And that has been applied, in fact, in trauma literature with relatively good results, that you can use single-cell multiomics as a predictor of 30-day morbidity and mortality in polytrauma patients. And I think you can extrapolate that to surgery, and specific in spine surgery, because you can think of trauma as a high entropy physiological stress and surgery as a controlled low entropy physiological stress. The other concept that is lost in an invasiveness index score is that it doesn't capture who the patient is that's undergoing surgery. If you have the same blood loss and duration of surgery, you have to think about, is it me who is having this surgery, or is it my 85-year-old grandma? So that concept is captured in frailty and has been adopted in, again, adult spinal deformity. And I come to adult spinal deformity because I think of, our techniques being really pushed to the edge in adult spinal deformity. And there is a threshold that if you go past that threshold of frailty with the same invasiveness of the operation, the complications and the revision rates go really high. That's where the impetus comes in for the MIS techniques. And I'm not going to define MIS techniques. I'm basically referring to what Phil was alluding, that I think we all know what we're talking about. Essentially, if you're not doing midline dissection, you're doing minimally invasive spine surgery as long as you're accomplishing those goals of the operation. So the impetus for action is that we have these increasingly frail patients who are getting small, or were getting small operations, and they will fail, and they will have a bigger operation to fix that. So MIS is supposed to address that gap between the frailty of the patients and the amount of physiological stress that they have to go through to accomplish the goals of operation that has been set in open surgery. So before I move on, I want to really emphasize how far the MIS techniques have come, because surgeries that were inconceivable 10, 15, 20 years ago are now part of a regular vernaculum of a PGY2 resident to have MIS approaches to treat big problems. So with that in mind, I want to see if we can compare what we can do with MIS on the left than what we do in open on the right. Is there a comparison between the two? And again, I'll look at the adult spinal deformity literature, and this is the latest one. It is from 2021, but it's the latest one from ISSG. But you can see that you can achieve similar MCID, but less blood loss with longer operative time. And anybody who does MI surgery, you know that we spend more time with the patient, that saves blood loss. But there is a paradox here, because I just talked to you about the invasiveness index score, where the bigger the surgery, the more the operative time, the more the blood loss, the more the invasiveness. But MIS is not going to follow that equation, because we spend more time to save the patient the blood loss. So you can't apply those index scores. And furthermore, you don't even have the same language. Look at the index score for adult spinal deformity. Anterior lumbar fusion, which is a workhorse, especially at 5'1", for MIS has a score of 8, and a grade 2 osteotomy has a score of 1. I don't think any MIS surgeon would agree to apply this score to their surgery. So we basically lost in translation. We can't communicate from one surgery to the other, from open to MIS. So this becomes a very tough question, that if you do a T10 to pelvis with open technique, and if you do it with MIS technique, which one is more invasive? I think it's intuitive to say the open one, but by how much? That's a very tough question to answer, and I don't think we have the tools to answer that yet. But the way I conceptualize it is that if you have an open, in open surgery, the more complex the surgery is, the more invasive. And with MIS, you have an opportunity for a few levels, and I'm not sure what that number of levels is. Is it 4 or 5? I think it depends on who you ask, and again, I don't think we have the literature to back this up, that you can actually save the patient a tremendous amount of physiological stress, but there is an inflection point where now you're doing more and more levels, so you're adding to the physiological stress to the point that it becomes similarly invasive to an open surgery in terms of, again, the physiological stress that the patient goes through. So in conclusion, I think in index scores, which is the only tool that we have so far, are inherently limited, and we should strive to measure the personalized physiological stress as a common language to speak between open and MIS, which are ultimately both spine surgery. Thank you very much.